Hello, my name is David Madden. I work for a company called Icon, and I want to tell you a little bit about our company. With rapid changing technologies and staff turnover, the challenge to keep clinicians knowledgeable of products, services, and technology has become increasingly difficult. Icon, Intensive Care Online Network, is an independent company established to provide clinical and educational support for healthcare professionals in the intensive care environment. Icon has recently partnered with Draeger Medical and supports the Avita series ventilator. These ventilators consist of the Avita 2 Dura, the Avita 4, and the Avita XL. Icon and Draeger believe that education and continuing professional development are vital to improving care delivery in the ICU. Icon's preferred customer program for the intensive care units include policy and program development, protocols, competencies, online education, and educational teleconferencing, along with a 24-hour critical care communication center. The Icon Communication Center includes intensive care physicians, nurses, nurse practitioners, respiratory care practitioners, and information technology specialists. To help you better understand what Icon is capable of doing for you, I would like to demonstrate a clinical call to Icon. What I'm going to do now is I'm going to demonstrate a typical call that Icon would take from one of our Draeger customers. So I'm going to call the 1-800 number and we're going to speak to Milo Frawley.
Thank you for calling Icon. Please hold. Your call is important to us.
Good afternoon, Icon.
Yes, my name is David Madden. I'm a respiratory therapist here in Las Vegas, and I'm interested in some information on airway pressure release ventilation. Is there anything you could tell me about that?
Absolutely, Dave. Glad you called. Aprv is a relatively simple concept to follow. We look at it as being CPAP with releases. So if you look at this graphic we have here of the airway pressure, we can see that there's this constant airway pressure is being held, and then there are these brief releases down. Some of the terminology that's important to understand when using Aprv, first of all, the P high, or the high airway pressure, and that's the level that we set this upper pressure level at. The P low, understandably, is the lower pressure level that we set. Two other terms, the T high, or the high time, is the length of time that we hold P high for. And then T low is the length of time that we hold the low pressure for. The breathing with Aprv, the airway pressure release ventilation breathing pattern, is a little bit different to what we see with conventional modes of ventilation. And in fact, what we often see is the lungs are being held open or inflated for quite some period of time, and then there are these brief releases as the airway pressure is released to a lower level. This is almost the opposite to conventional ventilation, where we tend to spend a lot more time at a lower pressure level or a PEEP level, and transiently raise inflation pressure. Aprv comes with some very distinct advantages, and it's no longer a matter of boxing or trying to confine the patient to the limitations of the ventilator. Now the patient's able to dictate more to the ventilator what they require. And we see this in the form, first of all, of spontaneous breathing. So the patients are able to spontaneously breathe, and doing so, they're maximizing on some very real benefits. First of these is this improved VQ matching. There's also improvement of recruitment of alveoli, of collapsed alveoli rather. And finally, we have an improvement in cardiac output associated with spontaneous breathing. Aprv maximizes on recruitment. It does this by maintaining pressure over time and utilizing collateral channels of ventilation to recruit back alveoli that have collapsed down. We're also able to prevent de-recruitment from occurring, and we do that by utilizing this short T-low and maintaining, as a result, end expiratory lung volume. We can promote comfort with this mode because the patients are having a lot more control, and as a result, we've seen from various research studies that there is a decrease in the amount of sedation required. And we have seen a virtual elimination of the need for neuromuscular blockade with the utilization of Aprv. If I could pick out two important points, Dave, just to run through with you right now, I would choose to talk about the setting of the T-low, probably the most important setting that we can that we do when we're using Aprv, and we do that by looking at the expiratory gas flow curve. And the goal here is to no longer allow the expiratory gas flow curve to come all the way back to the baseline that we may see with conventional modes. What we do is we intentionally terminate this at around the 50% mark of whatever the peak expiratory gas flow is. So in this instance, the peak is probably somewhere around 80, and we're looking at this case to terminate at about 50%, which is around 40 liters a minute of expiratory gas flow. Now, I can just show you, I happen to have a test lung on here at the moment, and I've got simulating a patient on Aprv, and first of all we can see some spontaneous breaths being taken there at the upper pressure level. The second point just to bring out here is that my peak expiratory gas flow under these circumstances is around 60 liters a minute, and so I'm terminating at this point here, which is around 30 liters a minute. The second most important point to understand with Aprv is the idea of how to wean. And we utilize a technique here known as drop and stretch. And this is a fairly simple concept. What we do is we drop the P high as we stretch out on the T high. And in doing so, we have a gradual lowering of mean airway pressure, and this allows for the alveoli to stabilize. And as the patient takes over more of the responsibility of the work of breathing, we are able to continually lower by dropping and stretching the pressure and time. Once we get down to probably around 15 centimeters of water for our pressure and around 15 seconds or so for our time, we're almost on CPAP, and so we would transition from there to CPAP, and we would make sure that we already have automatic tube compensation, or ATC, in place. So in conclusion, Dave, there's some very simple points to, this is rather a relatively simple concept to understand, but it still warrants great respect, and certainly if you're a new user, we'd just be delighted to hear from you and hear you call into ICON and check and confirm with any settings or thoughts that you may have. We think of Aprv as just being CPAP with release. It certainly enhances patient comfort, and we've seen this from the decrease in the amount of sedation that is being used and the near elimination of neuromuscular blockade. We're able to maximize on these benefits of spontaneous breathing, and in particular here I think of the improvement in VQ matching and also the recruitment of alveoli. The recruitment principle is enhanced by Aprv in that we can maintain pressure over time and utilize the collateral channels to recruit back alveoli that are collapsed down, and also we're able to prevent de-recruitment from occurring by maximizing on these short release times and thus maintaining end expiratory lung volume. Dave, we remain available. If you've got any questions right now, I'd be very happy to answer them.
Thank you, Milo. Okay. Have a good day.
You too now.
So that essentially is a typical call that ICON takes on a daily basis. What you witnessed was Milo Frawley taking that call and then enhancing it with an educational teleconference as well. In conclusion, what I would like to say is ICON recognizes the complexities and demands placed on the intensive care clinician to deliver the best possible care. ICON's ICU services and solutions are designed to reduce the burden of the busy clinician striving to keep pace with ICU demands. Thank you very much.